Thank you very much, and thank you for this webinar on building tomorrow's healthcare, financing resilience, and replicable infrastructure models. This webinar is organized by the Future of Hospitals and Health System Initiative, the Climate Action Accelerator, l'Agence Française de Développement, and the Coalition for Social Investment. This webinar will be recorded and will be available on the Accelerator's website and the related YouTube channel. Your audio and video are off by default, but you can ask questions using the Q&A option that we have on Zoom. There's also a translation to French that is available on Zoom as well, so you need to click on the option. I'm Carl Blanchet. I'm a professor at the Faculty of Medicine at University of Geneva, and it's a pleasure for me to facilitate this webinar. I also want to thank Sonia Rossmann for the support provided to organize this webinar. Talking about resilience and health facilities and hospitals is very timely today. We talk a lot about health facilities being vulnerable to extreme weather, energy shocks, and supply chain disruptions. So in this kind of new environment, we need to rethink on how to define, measure, and manage resilience of hospitals and health facilities and health systems. And there's great momentum. The Asian Infrastructure Investment Bank has launched the 2025 Asian Infrastructure Finance Report titled Infrastructure for Planetary Health, urging infrastructure development to prioritize health, climate, and nature to save lives and protect the planet. And today at the COP 30 organized in Brazil, we launched the Belém Health Action Plan for the adaptation of the health sector to climate change. Our webinar is also taking place while the World Hospital Congress is taking place in Geneva, and there's a fantastic theme this year, which is about global learning, local action for every patient. So what we have in mind when we talk about resilience of health facilities and hospitals and health systems is very much trying to think about sustainable resilience and low carbon healthcare provision. And that resonates very much on infrastructure, financing, and replicable models. What we also have in mind through the webinar is to try to make sense of how we define resilience. What kind of solutions we can put in place, what kind of priorities and what kind of investment we can make in various health systems where we work. These webinars, we have several sections. One of them, we're going to have 2 welcome addresses, and we're going to have fantastic 3 speakers who are going to present their views and their case studies. You will have the opportunity through the Q&A option to actually ask questions and interact with the speakers. So for the welcome addresses, we have 2 great speakers. We have Isabelle Brun, who is a Sector Policy and Partnerships Advisor, at the Technical Assessment and Monitoring Directorate at the Council of Europe Development Bank. And we have Amy Savage, who is Technical Officer at the Climate Change and Health Department at the World Health Organization. So without any waiting, I would like to give the floor to Isabelle, who is going to give an intro on this webinar. Isabelle.
Thank you, Carl, and hello, everybody. Very nice to be with you today. Thank you for the opportunity to join you. I'm gonna indeed say a few words on behalf of the Coalition for Social Investment of Finance in Common, which I represent today. Let me start with some brief context on the FIX initiative and on this coalition. Finance in Common, as you may know, is the community that gathers all the public development banks in the world, around 540, I think, at the latest count. It was launched in 2020, and it has been organizing yearly summits since then. It has grown in an all-year-round initiative that produces prime research and knowledge, and is actually increasingly convened as the voice of public development banks contributing to the development finance conversations, such as recently in the FFD4 summit in Sevilla, and also in the social summit in Doha in Qatar. Public development banks and multilateral development banks, such as the CB, where I work, are critical players of the global development finance architecture. We, as development banks, help prepare investment-ready projects and channel funds effectively. And this is why cooperation amongst PDBs and MDBs, and with other key stakeholders, are essential to deliver effective development results. As I mentioned, I represent today the coalition, which the CEB co-leads with the Agence Française de Développement, and colleagues are online. We represent a group of around 30 public development banks as a subgroup of the FIX initiative, and also our sponsors and stakeholders, namely the ILO, the UNDP, UNESCO, and WHO. This coalition was launched in 2021, and we are committed together to increase both the quality and the volume of social investment globally. We do this via 3 pillars: advocacy, knowledge, and action. And amongst our achievements, we have some survey on social investment to map what social investment needs and meets amongst all of our members. We also have done an advocacy paper on social climate nexus, which is also relevant to today's conversation. And we have 3 active work streams: one on social protection and decent jobs, one on education, which has just been launched, and one important one and very active one on climate health, which gathers us here today as well. Before moving to the topic, one last word on why platforms such as these coalitions are important. First, Finance in Common has organized itself to be operational through coalitions. We, as a group of members with interest in social investment, are the ones that carry the voice of social investment, and we help Finance in Common carry that voice in the international community. More practically, a platform such as the coalition can help promote and leverage existing initiatives, identify both gaps and similarities or replicable projects across geographies, which is not often the case. And we also can help connect practitioners and countries and investors with PDBs. So the webinar such as today exactly aims at doing that. And again, grateful for the colleagues who organized this. Now, on the topic itself, as we all know, climate change represents a growing risk to human health, and it is widely recognized as the greatest global health threat of the 21st century. It drives a surge in both communicable and non-communicable diseases. As a matter of fact, a World Bank study estimates that climate change could cause over 15.6 million deaths by 2050. Climate change also exacerbates mental health challenges, including anxiety, post-traumatic stress, and social disruption, while at the same time worsening chronic diseases linked to air pollution, such as cancers, cardiovascular, respiratory, and neurological diseases. The climate crisis, importantly, is inequitable. It affects, for example, many lower and medium income countries, while these have contributed the least to global emissions. Within countries, marginalized individuals, communities, and groups, which we identify as the most vulnerable population in our work at the CB, are the ones paying the highest price, with climate change acting as a threat multiplier. Due to biological differences and gender norms, women, children, and adolescents are actually disproportionately affected by climate change. Large-scale extreme weather events are putting significant pressure on health systems, including on infrastructure, but also on healthcare workers and on supply chains. And this pressure is impeding the ability of health systems to respond effectively, and in turn amplifies the overall health risk of climate change, especially in countries and regions more vulnerable to natural hazards. At the same time, let's not forget that the health sector itself contributes to about 5% of global greenhouse gas emissions. Most of these emissions come from the production, procurement, and transport of medical goods. When putting all these considerations in the perspective of today's topic, tomorrow's healthcare, I can share our experience at the CB as a financier of social projects and based on our exchange of knowledge with peers and organizations, including, for example, our latest work with the WHO, with whom we work on hospital infrastructure jointly with peers, including IFD colleagues who are on the call. As a social development bank, we care about resilient healthcare, which is accessible to all, and we try to focus efforts on 3 points. The first point is crisis resilience. Health infrastructure and health services should maintain essential functions during pandemics, during natural disasters, including heat waves or economic shocks. And we have seen the weakness of those systems in the recent crises, including the COVID crisis a couple of years ago. The second point is universal accessibility. Healthcare shall remain available and affordable for all populations, including the most vulnerable or the marginalized groups. And the third point is on adaptability and innovation. As flexible health systems, integrating technology, continuous staff training, and efficient resource management are the ones that are needed to meet the changing needs. So flexible infrastructure is needed also to adapt to crisis situations. I'll leave it at that. Thanks again to colleagues from IFD and the Climate Action Accelerator for putting together this great event. And I'm looking forward to the discussions, even though I can only stay about 1 hour with you due to a prior commitment. But I'm really looking forward. Thank you for your attention, and feel free to reach out if you want to know more about Finance in Common or about the Coalition for Social Investment.
Thank you very much, Isabelle. Thank you very much for this great opening, really highlighting not only some key issues related to inequities between countries, within countries, and your 3 action points or 3 pillars are really, really essential and very well formulated. So thank you very much for this great opening. Thank you very much, Isabelle. I want to give the floor to Amy. Amy, who is going to talk a lot about in this opening on the coalition on the Alliance for Transformative Action on Climate and Health. Amy, the floor is yours, and maybe we can have Amy on the camera.
Thanks so much, Carl, and good afternoon, everyone. It's really a pleasure to join you all here today as we explore how to finance and scale health infrastructure that is resilient, sustainable, and prepared for climate risk. First, let me thank Isabelle for her insightful opening remarks and for setting the scene, and of course, extend my appreciation to the organizers for convening this dialogue. WHO greatly values our collaboration with the Climate Action Accelerator to advance climate and health action. Despite the clear and growing risks of climate change to our health, we do know that the health sector remains one of the most underfunded sectors when it comes to climate finance. But the health community has really recognized the importance of climate risk to health. At a global level, the commitment is clear. Climate change is the first of 6 strategic objectives of WHO's 14th General Programme of Work. A resolution on climate change and health was adopted at the World Health Assembly last year, and the Global Action Plan for that resolution was endorsed at this year's Assembly. And health has also been seeing growing attention in climate negotiations. And as Carl mentioned, as we speak, the COP30 is taking place in Brazil, and the Belém Health Action Plan is being launched actually right at this moment to open the Health Day, which is today. And for implementation of climate change and health priorities, including those that have come out of the COPs over the last few years, WHO is hosting a network called the ATTACH, the Alliance for Transformative Action on Climate and Health. This was established in 2022 out of the COP26 Health Programme. And the ATTACH now brings together over 100 countries and 90 partners with a real focus on implementation of climate change and health actions, including climate resilient, environmentally sustainable, and low emissions health infrastructure. We often say that healthcare facilities are the front line of climate change because they're increasingly vulnerable to the impacts of climate change, while also facing the burden of treating a rise in climate-related illnesses. Extreme weather disrupts services when communities need them the most, while long-term climate impacts are increasing the burden on our health facilities. But at the same time, as Isabelle mentioned, the health sector does contribute to greenhouse gas emissions, so we have a responsibility to act. Climate resilient and low carbon health infrastructure is essential. It ensures continuity of care during emergencies, reduces environmental impact, and often lowers operating costs through energy efficiency and renewable energy solutions. For example, the WHO 2025 investment case showed that electrification of healthcare facilities could save approximately 290,000 lives annually, while at the same time reducing emissions and increasing resilience. WHO has been supporting countries in this work of climate resilient, environmentally sustainable healthcare facilities for many years and have developed tools like our guidances and checklists for vulnerability assessments. And these guidance documents help governments to assess risks and design facilities that can withstand climate shocks while reducing emissions. And also at COP30, tomorrow on Attach Day, we'll be launching our new guidance on measuring greenhouse gas emissions of health systems. And I'll pop a link in the chat to the site where the document will be uploaded tomorrow morning. And today's discussion is vital. These solutions need to be scalable and affordable so every country can adapt them to local context. Every dollar invested in resilient, low carbon health infrastructure is an investment in healthier communities and a safer planet. As we move forward, let's make resilience and sustainability a standard part of health planning and investment. By working together through initiatives like the Attach, we can build health systems and facilities that address and reduce the health risks of climate change. Thank you again to the Climate Action Accelerator for hosting this important conversation and for our ongoing collaboration. And thank you all for being a part of this dialogue. Thank you.
Thank you very much, Amy. Thank you for reminding that health facilities are going to be on the front line of the response when it's about climate change, but as well as Isabel highlighted in the opening remarks, it does require that these facilities and the people who work in these facilities needs to be adaptable and agile to respond to a constant changing environment. Thank you very much, Amy. Thank you very much, Isabel. So now I want to give the floor to our three speakers, and our first speaker is going to be Vera Sergio, who is going to, Vera is a senior One Health scientist at the Asian Infrastructure Investment Bank. And as I said in my introduction, a report had just been released on the infrastructure for planetary health. And I do think we're going to hear a few words about that. Thank you very much, Vera.
Thank you so much, Carl, and good morning, good evening, good night for me here in Beijing almost. And very happy to be part of this conversation and also hopefully have a bit of a interaction with some of you in the end. So let me see if I can share my screen here, and I will try to present some slides for you and walk you through a little bit our thinking in AIIB. I hope you can see the slides. I assume that.
Perfect.
Okay,
perfect.
fantastic.
Thank you.
So for those who don't know, Asian Infrastructure Investment Bank, we are the newest kid on the block. We are about 10 years old, and we are the newest multilateral development bank. So Asia is in our name, but we actually work globally. So we have core investment sectors as urban, transport, energy, and so forth. And as of last year, actually, we launched our first health strategy. And in that came the thinking of what do we need to think about when we think about health investments for the future, and what is needed, and how can we as an infrastructure investment bank or multilateral development bank really facilitate and help our client member countries to think through this health system in a changing time. So as I mentioned, we are quite new, but at our core is really the focus on both environmental, social, and financial sustainability of all of our projects. And I particularly lead a bit of the thought leadership work at the bank, so focusing in on, what do we need to think about for the future, And as Carl mentioned, we just released earlier this year, actually, a new flagship report on infrastructure for planetary health. And I'll walk you through a little bit of that. But the prior 2 years, we had on nature's infrastructure, which I will also come back to, and then also a moonshot for the emerging world. So how to build state capacity and private sector investments into the net zero transition. So I think important of this conversation is we'll talk about healthcare infrastructure, but actually the outset of this report was really trying to kind of say that the vast majority of what affects our health is actually outside of the healthcare sector. And there's a need to think more holistically about what affects our health and how we sort of can take a more holistic approach on tackling health. So, only about 10% of what affects our health is actually in relation to whether we have access to healthcare facilities or medicines and so forth. But the vast majority has to do with whether you have access to clean air, clean water, education, and so forth. So that was really our approach, and how can we think through this from a sort of a fresh perspective of being a new institution. So we conducted and finalized this report, and I invite everyone to look it up and have a read through it. We did a lot of different chapters that looked on different types of health risks and what needs to be done sort of for the future, and how do we need to think about these emerging challenges. We have had enormous progress in public health in the last 50 years. I think this is news for no one on this call. But we are now seeing a threat to these gains from changes to climate and nature degradation and so forth. So our report really highlighted both what is happening right now in terms of escalating threats both to our health, to critical infrastructure, including healthcare infrastructure, and also what are some of the solutions. We looked at a lot of the innovative solutions that have been there in terms of reducing air quality, specifically focusing in on China's transition, looking at countries that have also improved efficiency and more resilient health infrastructure, looking at different impacts from extreme floods, droughts, and heat waves and so forth. So I won't take too much time to go into the depth of the report, but I think the important thing that came out of this report is we really thought that we need to change our thinking through really a paradigm shift, and that is to think through sort of a planetary health lens, that where we think about every piece of infrastructure, whether that is being actually a healthcare facility or that is being a road, how can we think about that piece of infrastructure to optimize health outcomes? And in that also looking at how can we optimize climate mitigation and adaptation, and how can we look at optimizing nature conservation and restoration. Easier said than done, but I think there's a lot of good evidence now that I will showcase in a little bit of what can actually be done to sort of incorporate more of planetary health approach. I think the other point is that nature is really important, and we really looked at that from our nature's infrastructure report. So how can we actually incorporate different types of nature-based solutions or nature as infrastructure, both to optimize climate mitigation adaptation, but also to look at improved health outcomes. So I'll also show some examples of that. And then really, improving access to equitable healthcare, of course, and green and sustainable healthcare, and then really strengthen global collaboration, which I'll speak to a little bit. And then last but not least, closing the financial gaps, and how can we actually mobilizing financing from other sectors, whether that being the climate sector or whether that being the infrastructure sector, to get more financing into healthcare. So that was a little bit the approach, and we then launched our healthcare strategy, our first healthcare strategy, which clearly outlines the importance of green and climate resilient systems, but also looking at health across the entire lens of infrastructure, as well as technology and mobilizing private sector financing and so forth. So coming back to nature, I think this is something that we have seen in a lot of our projects, and we try to sort of incorporate. So nature can be sort of nature as infrastructure, where we look at specific areas. We've seen, we have a big project now in the south of Brazil, in Rio Grande do Sul, where about 400 healthcare facilities were flooded during extreme floods. And as we're now supporting the Brazilian government to rebuild these facilities, we're also looking at, what are the needs in terms of creating new and resilient healthcare systems and healthcare facilities. And we see nature as a critical component of that. Mangroves, to just take one example, is an extremely effective coastal protection, both for people and for infrastructure. And it has about 3 times the carbon capture of normal forests, provides livelihood, and a lot of other important resources to population living in those areas. So this is just one way to look at how we can actually utilize nature as infrastructure to protect health infrastructure. And this is very outlined in this project. Then we have the sort of the green and gray infrastructure combination, which is in the center, where we see a lot of now healthcare facilities, for example, utilizing green roofings, improving park areas around the healthcare facilities and so forth, to optimize both the area of the healthcare facilities itself and optimizing air quality, but as well as cooling effects of having green walls and so forth. Another project that I just wanted, these are actually pictures from a long time ago, on the left side, when I was in the Philippines, and specifically assisted mayors to rebuild healthcare facilities after the devastating effects of Typhoon Haiyan. This was in 2003. Now we're also seeing that one way to actually look at mitigating some of this impact is also building in different types of infrastructure around urban setting. So on the right side, you have and a project that we did in Indonesia, looking at low house communities and how you can integrate different types of wet landscape, but also flood based solutions. And on the very low end, you have what is now being implemented in a lot of Chinese cities, which is basically swamp cities. So that's another example. I'll try to wrap up here now, as I've seen time ticking away. But the final point and the final slide here is really like, how do you incorporate and utilize other sectors' financing to improve healthcare financing? I just want to take this example because this project was just approved and is being launched now in Belém as we speak. This is a project, it's called a climate policy-based financing. So we provided a $1 billion lending to the Brazilian government, basically to improve and support their policy landscape for climate adaptation and mitigation. A big part of this project is actually looking at, which is going to be launched now today. It's called AdaptaSUS. So it's a national health strategy, adaptation strategy, and mitigation strategy for the entire Brazilian healthcare system. This is one of the biggest healthcare systems in the world in terms of patient access. And there we specifically also looked at not only the sort of mitigation, how do we actually reduce the carbon footprint, but how do we actually look at pointing out where these facilities are and how can we improve them. And then also incorporating early warning systems, both for heat and air pollution. So that was a very, very densely comprised presentation, but I hope that inspires some ideas. And again, very happy to for questions or for anyone who feels like reaching out. Thank you so much.
Thank you very much. Thank you very much, Vera. It was very enlightening just to learn about all these concrete examples on how the health sector can adapt and can go beyond actually health, and also very, very enlightening to hear about how new sources of funding can actually be used to invest on health. and beyond as well. So thank you very much, Vera. Thank you very much. Our second speaker now is Raymond Bertrand, who is an healthcare architect for Morgan Consulting Engineers, and he's going to talk about strategic planning for resilient health infrastructure. Raymond, the floor is yours. If you put your camera on.
Thank you, Carl. But the camera doesn't work actually here because the
no
brand,
problem.
I'm in Africa and the brand is very low, so I'm sorry. Yeah, so I just want to introduce myself. So I'm Raymond Bertrand, originally from Canada. I'm a healthcare architect. I've been working essentially in healthcare for 35 years. And I lived also in France for 15 years. I worked for Jacobs Engineering, which is a large engineering company as a medical planner. And I've been working in about 50 countries up to now, but mostly involved in Africa. And I've lately been looking at I'm doing research on resilience of hospitals in Africa, which is a big issue, as Vera was saying, not just for the natural disasters, but also for the pandemics. We've been through COVID-19, as you know, and I worked at in the USA for Rush University Hospital, which is a 1,000 bed facility in Chicago, and it was actually the first hospital to be designed for pandemics after COVID-19. That involves, for instance, converting acute care bedrooms into ICUs. This was a big issue when we had COVID. Because I've been also 18 years in the military as a healthcare administrator, managing field hospitals. And I was in France. We managed a hospital there, a field hospital, because there was not enough bed in West Hospital in Lille. So we had to, set up tents and everything to have these patients to be ventilated outside from the hospital. Now, adaptability is, in terms of resilience for hospitals, is a very important factor. You have now to what we call universal bedrooms. So we set up bedrooms for acute care, but also that can be converted for intensive care. So you put the ventilator and the patient doesn't have to be transferred into an ICU unit. So there are two things in Africa. As Vera said, there's the natural disasters, flooding, earthquakes, and so on, but there's also the pandemics, like COVID or Ebola. And so we have to plan for hospitals which will be ready. There's a readiness to be to answer these epidemics. For instance, mass triage. Mass triage is a big thing. When I was in Quebec, we had the SARS. And SARS, we had to mass vaccinated people by thousands and thousands every day in some hospitals. But the hospitals were not planned for that, because there was only like a 50 seat or 75 seat waiting area. So we had to set up tents outside from the hospital. The Red Cross was involved and everything. So this is not, if this is not planned in advance, the responses of the hospital will not be adequate. So this is something we need to do. So in Africa, I was involved. I've been working for 20 years now, and I worked for the AFD, the World Bank, European Bank, the United Nations, Enabel from Belgium, in Congo Kinshasa, and the USAID. So I worked in about 15 countries, and I did over 600 health facilities assessment. What they usually do, whenever they want to invest into retrofitting hospitals, first of all, they do a feasibility study, and then we need to do an assessment of the existing facilities to see whether or not they should be demolished, or they can be renovated or retrofitted. So this is an important phase when you do this, because this is when you have the opportunity to upgrade the facilities so that they can be more resilient and more sustainable. Most of the hospitals or even the healthcare centers in Africa, the problem is the quality of building. The materials that they're using, the systems that they're using is not adequate. Sometimes the design approach that most of the African countries, since they were colonized, unfortunately, or models imported from Europe or from America that they don't reflect the local culture. Local culture, you have to understand how people are interacting with the health system. When I was in Guinea-Conakry, for instance, during the Ebola crisis in Nzérékoré, at one point, it was the epicenter of the Ebola, patient number 0, which was a small child, actually, that took a bat on the ground, and he was eating the bat, and the bat had the Ebola virus. That's how it started. But at some point, patients were coming into hospital, one hospital in particular, and they were obviously they were dying. We had a 90% death rate. So the population of the village, they came to the hospital, and then with machetes, and then they killed the director, they killed the nurse and everything, because they thought that people in the hospital were killing the patients. So, and then we had to bring doctors from USAID to educate the population and say, no, you're not killing them. You know, that's how it is. So, I mean, the cultural aspect is very important, not just relating to the services per se. Currently, I have a project here in Rwanda, in Musanze, and they're reintroducing traditional medicine within the modern hospital. This is good. So this is a big change. It goes away from the European or American approach. So this is one thing. The other thing is adaptability. There's two things in a hospital setting: flexibility and adaptability. Flexibility is the ability to move walls and to change according to new requirements. Adaptability is that you don't move the walls, but you keep the same room, but it can be converted into something else. And this is better in terms of resilience than having to tear walls and move things. So once we assess the existing structure, then the next step obviously is to do design and everything, but we have to look also with the local the site. The site is important when for flood, for instance. Is the site inclined to be flooded or not? Because this is a big issue. I was in Chad 2 months ago. I assessed 60 hospitals, and there was a big event of flood in Chad this year, early, I think in February. Many hospitals were flooded. So we have to assess the site, whether it's in a seismic environment, like the one that was a big seismic event in Haiti 15 years ago. There was an earthquake, and the major hospital was almost demolished. So then we had to send actually from Red Cross, we had to send a team there to relieve the hospital. And one important thing to do also is once you have a new facility being built, there is what we call the post-occupancy evaluation. So after a year or so, you have a team that can come in and then evaluate how the facility is functioning for all the systems and, you know, is staff happy with the facility and so on. So there's lessons learned. The design process, it's a spin-off. It's not like a linear thing. It's a spin-off. And then what the lessons learned, what you have from a post-occupancy evaluation, you can reintegrate it into new facilities. And sure, final thing I would want to say is sustainability. So again, sustainability is important. Reducing maintenance cost. Again, many of the hospitals in Africa are still being electrified by the grid, and most of them they don't have electricity for about 8 hours. There's a lot of outbreaks, and there are solutions to make them more autonomous. Reuse the water. The wastewater can be reused and treated with what we call phytoreparation, and then they can have cogeneration. You burn fossil, and then it generates electricity through a turbine. It produces steam, and the turbine produces electricity. So the hospital is some sort of out of the grid. It's autonomous. So these are solutions for resilience.
Excellent. Thank you very much, Raymond.
Yep.
Thank you very much for making differences between flexibility and adaptability, for highlighting the importance of culture as well in your talk. Thank you very much for this talk. Thank you very much.
Thank you.
As our third speaker, we have Serge Troary, who is an architect and a construction project manager in Beirut for the RCRC, the International Committee of the Red Cross. And Serge is going to say a few words about the RCRC Resident Hospital in Lebanon. Serge. Serge, if you talk, you're on mute.
Okay. Thank you, everyone. And thank you for the opportunity to contribute to this important topic. Today, based on ICRC's work in Lebanon, I will briefly present how climate resilient infrastructure intervention is beyond technical or infrastructure intervention, but a key foundation that enables hospitals to maintain continuous, safe, and high healthcare services during crisis, of which climate change is becoming the most critical one. Lebanon's public health system is at its crucial crossroads. Hospitals are navigating the combined pressure of economic collapse, resource shortages, heat waves, and also infrastructure deterioration, all intensifying under global climate crisis. Rafik Hariri University is the country's largest public and referral facility and became the focal point of ICRC's long-term engagement since 2016 with the support of Avena Stuffing, Agence Française de Développement, and also King Salman Humanitarian Aid, which started from 2019 and up to today. What initially began as urgent post-crisis repairs gradually transformed into a strategic resilience program that aimed at ensuring that life-saving services such as surgical services, ICU dialysis, and emergency care remain operational no matter the external shock. The overarching challenge really that we faced was how to keep the hospital functioning reliably when energy systems fail, temperatures rise, and water availability becomes unpredictable, as is mostly the case in the context that ICRC operates in. The climate crisis has fundamentally altered the nature of our work. As ICRC no longer only respond to crisis and violence as such, which we continue to do so, but also address the environmental and climate change risks in the interventions that we do. At RHUH, part of the interventions that we did was to integrate climate projections into our interventions, whereby we not only provide solutions that answers what currently the hospitals needs, but to make sure that the systems that are put in place are planned and designed with future projections that could handle the future climate shock. This forward-looking approach ensures that hospital systems will remain functional even under higher temperatures, heat waves, and increased freshwater scarcity. which are projected for Lebanon also in coming decades. Our interventions were guided by ICRC's 5-pillar health infrastructure resilience model. One, the energy resilience, where we ensure that uninterrupted power for critical equipment to ensure infection control and surgical safety of our beneficiaries. Water resilience, where we ensure we secure water quality, storage, and redundancy to ensure safe water for key services like sterilization, dialysis services during the crisis. There is functional and operational resilience as well, ensuring that whatever we put in place, there is the capacity building to the local partners to handle these systems, even in the absence of the ICRC. And this integrated model, which was applied in RHUH, enabled RHUH to sustain quality care before and during the crisis, not only when conditions are stable, but also when there is also differences in the waves of different shocks that they face. And our holistic approach really begins by identifying critical climatic parameters, such as rising temperatures, that we take into factor during the design processes, because it is at the start of this process that the key evaluations take place to ensure that the key parameters are also integrated. And we also ensure that design decisions design decisions and design solutions that are put in place could be found on the local market, not only in terms of materials, but also expertise. And through this as well, to ensure that there is a measurable system to measure the results that we are achieving into our intervention, of which in Rafika really integrated a system called BMS, Building Management System, to make sure that these results that we expect from these systems could be tracked, and also could be translated and replicable in other contexts. And the same as we mentioned in part of our projections are the interventions we put like in the HVAC systems to make sure that there is a chill and heat recovery system, all to make sure that the key clinical services, especially like in operating theaters, could continue, and also to provide redundancy in the water system. Like when ICRC intervened in RHUH, there was only municipality water, but we put a system in place for treatment also of the seawater, to make sure that the hospital does not only depend on one source, but to create redundancy and to ensure a continuous freshwater supply for key services, for sterilization, dialysis, and to make sure that all this could keep on running without necessarily affecting the hospital operation. And part of that, as well as mentioned, was to put also systems in place like BMS, Building Management System integration, to also help the hospital manage where the resources that they have, and to also help the hospital make data-driven decision in managing resources and utilizing resources, especially during the peak times of the crisis as well, to ensure that the key services remain operational, all for the quality of care of the patients and beneficiaries. And also part of the key things as well, as we mentioned, is to make sure that the hospital makes data-driven decision in monitoring not only the systems that are in place, managing the systems and that are also in place, to ensure that the operations of the hospitals are optimized and continue during these crises. And another key thing, based on the lessons learned that we have learned from ICRC, from Rafika really, ICRC in partnership with ETH Zurich developed a toolbox called Health Infrastructure Resilience Toolbox. The toolbox goes beyond traditional engineering checklists. It evaluates how hospital systems behave during real crisis conditions, including to make sure that the hospitals can be ready in case of mass casualty incidences, to make sure that the hospital can run different models during the tool to assess their preparedness of not only the crisis that they deal in terms of health crisis, but also the resources they have in place to make sure that they could address any challenges that they have. The same approach that we had really in Rafika, really in terms of forward thinking in planning, and also putting in place systems to facilitate dealing with the climate change. We're also replicable in other hospitals. Right now, we are applying the same model in the north, in Tripoli Governmental Hospital, But this, we are also scaling the same approach to the south of Lebanon in Tebnin and also Marjayoun government hospital to replicate this model in intervention and also in the monitoring using data-driven models to make sure that the hospital are resilient as much. The way forward for ICRC is to roll out the resilience tool across more contexts. The tool is now ready based on the lessons learned from ICRC. Now it is entering into global adaptation and pilot testing to ensure that it could be applied in other contexts, and also to bridge climate adapted infrastructure with health outcome resilience to ensure that every investment that we make not only addresses the climate risks that hospitals are facing, but also make sure that these investments translate into a safer, cleaner, and more reliable healthcare environments. In conclusion, with this for us, climate resilience infrastructure for ICRC is not only engineering achievement, it's a clinical life-saving necessity, designing hospitals for climate realities of the future to strengthen their ability to deliver essential care today and in most challenging conditions. And of course, such initiatives cannot be achieved without yearly planification and long-term commitment from our financing partners, such as IFD and also King Salman Relief for humanitarian activities, to make sure that such commitments could really be sustained. Because if these cannot really be achieved as only short-term things or one thing to do, but such commitment to continually commit to such projects or such models is something that really depend highly on such financing and also development partners as IFT. I thank you so much for your attention. Unless there's any question.
Thank you very much, Serge. Thank you. It's fascinating to hear an organization like ICRC who is actually dealing with that and then providing some very concrete solutions. But it's amazing to listen to you and how you have to deal with so many dimensions between climate, between energy efficiency, between patient safety and continuation of care. And all of that, you have to take into account all these aspects. I want to give the floor to Agnès Souka, who is the Director of the Health and Social Protection at the Agence Française de Développement, to tell us a few words before you leave. Agnès.
Thank you very much, and good afternoon to everyone. I'm sorry I have to leave this seminar early, which I really regret, because I really enjoyed the three presentations very much, because they really represent very clearly what we are doing right now at country level. So on behalf of AFD and the C4SI coalition that we have the honor to co-chair with the Council of European Development Bank, I would like to thank you, and especially these panelists and you, moderator, for this very interesting discussion. And I would like to thank the Climate Action Accelerator for the organization of this event. This type of seminar is exactly what the Finance in Common Summit and the Coalition for Social Investments want to promote: a platform of dialogue between experts, partners, countries, and funders. As already described, climate change is no longer an environmental issue. It has become a profound public health challenge, and it has become part of a broader agenda of planet and health that is very well captured by the new strategy of the AIB on planetary health. Rising temperature, extreme weather events, and environmental degradation are already reshaping health outcomes worldwide, spreading infections and vector-borne diseases, worsening malnutrition and water scarcity, and putting increasing pressure on fragile health systems. We know the World Bank has estimated that the economic cost of the health impact of climate change will reach between 8.6 and 20.8 trillion by 2050. We're talking about a massive impact. The needs are thus immense, but these investments also offer substantial social and economic returns, which really put them as priorities in terms of public policy and public investments. They critically contribute to the fight against inequalities, and in many ways, they are public goods. The direct benefits of investing in building the resilience of health systems to the impact of climate change are considerable. There are several examples already that demonstrate the scale of the potential returns on these investments. We know that the decrease in air pollution that would be the consequence of using less fossil fuel, burning less of it, could save up to 8 million lives. We know that electrifying healthcare facilities through renewable energy systems would save around 300,000 lives by 2025, and adapting water, sanitation, and hygiene to climate change would prevent close to 200,000 deaths annually. So solutions do exist, and the ecological transformation of our health systems must be robustly pursued and accelerated. This vital journey demands sustained investments in public policies that build interconnected health and ecosystems across multiple scales to truly enhance their resilience. We're moving from an agenda of health systems investments to an agenda of systems for health, which had been advocated for a few years ago by the Health Systems Research Alliance. Our development bank instruments must therefore deeply integrate this for a truly global, holistic approach. That's what we are advocating during these 2 weeks of COP30, and we are sponsoring different events to carry this message around. Public development banks are today uniquely positioned to drive this transformation because they combine financial strengths, technical expertise, and policy influence. Together, they can mobilize partners and capital at scale, and they can connect governments, private investors, and climate funds around shared goals. And this is what is already happening. The examples of Brazil that was presented earlier is testimony to that. Collectively, financing commons institutions manage of over $23 trillion in assets, representing more than 10% of global investments every year. And this amounts to about 2.3 trillion per year. This has to be put in perspective with development aid that for health represented 40 billion per year before the withdrawal of the US government from funding global health programs, and probably will amount this year and the following years to about 20 billion per year. So we're talking about mobilization of trillions that is of a different order of magnitude from the development of aid. This journey towards health systems adapted to the consequences of environmental challenges now demands investments in public policies. And these policies must build these interconnected health ecosystems across multiple scales to truly enhance their resilience. First, there is a critical need to rethink infrastructure itself. As we saw during this webinar, we have to focus on the environmental footprint and the climate resilience of systems for health by better integrating these systems within their natural surroundings. Tools exist for this. And for example, in France Agency for Development, we have a building energy efficiency program, which actively supports all our health infrastructure projects and lead to an average of 40% decrease of consumption of energy by hospitals. Secondly, it is essential to design more robust and decarbonize regional supply chains. This is an area where development banks are already investing. And AFD is really a proud contributor to these efforts, particularly in the post-COVID era, which shows the need to build the sovereignty of investments in the pharmaceutical sector. Furthermore, and this has been very well illustrated today, strengthening our health system in the face of climate change also means strengthening the human dimension. This goes beyond traditional care. Particularly, I really want to insist on the investments that are needed in prevention, nutrition, and epidemiological surveillance, that adopting a truly One Health approach that connects human, animal, and ecosystem health to invest in global public goods and overall commons for health, building institutions that collectively manage the challenges of health that humanity is facing. It is therefore crucial to consider health solutions as a territorial at a territorial level within this holistic perspective and rethinking access to infrastructure, governance, but also human resources. We in AFD are committed to advance this critical agenda, as is currently demonstrated by our ongoing collaboration with Professor Carl Blanchett on a position paper. And we hope that this significant piece of work will better guide development banks in investing effectively in resilient health systems. We anticipate this paper to be out by May 2026, marking a crucial step in our collective efforts to build evidence-based investment strategy that truly work. And we also intend, in partnership with the Climate Action Accelerator, to continue this crucial series of webinars. Therefore, we will organize a new joint event early next year to dive deeper into the challenges of hospital investment. As an example, we have today a proof of concept. In AFD, in 2024, we managed to invest more than 600 million euros in health investments that have climate benefits. That represents about 74% of our investment. So we know that it is possible to invest differently in the health sector and to invest in a way that contributes to the climate agenda. We really look forward to seeing you again in a few months to discuss these issues deeper with more examples, particularly more examples on health investments that are conducted today at country level. Thank you again for each and every one of you for your participation. Let's continue this journey together and translate this dialogue into concrete action for healthier, more resilient future. Thank you.
Thank you very much. Thank you very much, Agnès, and thank you, Isabel, because I know the two of you have to leave to another event. Thank you very much for taking the time to go to you. Let's open the Q&A session now, and then you can use the Q&A option on Zoom, and I can't see at the moment any, but don't hesitate to put a few to write a few comments or questions you would have for speakers. As a matter, trying to understand, I wanted to have some reflections, maybe from the three speakers, listening to each other. Some of the what kind of comments you would have, Vera, Serge, and Raymond, listening to each other, and how the presentations actually related to each other. And I can see a lot of commonalities. Vera, do you want to start? What you heard from Serge and Raymond?
Sure, thank you, Carl. No, I think what I hope is obvious here is that we need to work from many different angles, both from within the health sector, but also with other sectors, very importantly, to solve this issue. I think the good news is that we do have a lot of these solutions. We know how to build more resilient healthcare facilities. We know how to decarbonize them in quite effective ways. I just read a recent report that said, basically building a new green healthcare facility pretty much pays its return on investment after 6 years. That used to be 20 years, 30 years. So the actual cost of building resilient healthcare facilities has also dramatically reduced by the kind of lowering prices of renewable energy, such as solar and so forth. So I think the reality is that we can do it, but it's very important to align different resources. I'm also coming from, the financial sector, and the reality is also that a lot of the work that we do in terms of investing in new healthcare infrastructure needs to be informed by a lot of information on the ground. And that requires a multi-sectoral approach, really from community engagement groups who have better understanding of, what is the accessibility routes, to potential health facilities, locations, what are the healthcare needs, what are the barriers to care, what are the potential, energy uses and so forth can be implemented. So working across healthcare, engineering, climate sort of expertise, and I would argue also like nature expertise. I think it's both critical but also very, very difficult. So I think that is the important. And if we can all play a part in trying to bind different line ministries together as we have these conversations with different countries, I think that is also critically important. So good news is that we do have a lot of solution. The kind of more difficult aspect is how do we coordinate its work and actually make it reality.
Excellent. Yeah, thank you very much, Vera. And Serge, I was also amazed to read on your slide and when you presented as well the need for measuring. And I'm amazed by the number of tools you have developed to measure resilience. You have this rapid resilience assessment I'm fascinating about. And also, I can really see in your table when you presented the different solutions, and I'm like Vera, I'm amazed that today we have the capacity to do it and the technology to do it. You always have this need to measure actually where we are, and it's a great improvement compared to other sectors.
Yes, thanks a lot. Really, this was one of really the key intervention from the ICRC since our presence in Rafika, really in Lebanon from 2016, whereby towards the last few 2 years, we actually were thinking, how do we make sure that the solutions that are put in place here could be replicated, could be maybe exported to other contexts, real, but of course adapted to reflect those contexts, but with having concrete data and metrics to base on either to expand and scale. And this is where also part of ICRC's intervention was to make sure that whatever intervention that is put in place, there is a way that it could be captured into the different tools like the rapid assessment that has been put in place that was fed a lot on what has been done here in Rafika, really. But also the key link to this is to find a way to create a correlation between the engineering and infrastructure solution with the health component, because at most the engineering and infrastructure solutions were more interpreted in terms of, yes, 25% in water savings, yes, 50% in savings in HVAC and everything. But at the end of the day, how does this translate into healthcare? How does 25% in water savings translate into the clinical and the quality of health that the beneficiaries are getting? And part of the tool is also to bridge that gap, the gap, so that even if such models are taken to partners, they understand the win-win between investing into infrastructure resilience approaches with the benefit to the quality of care that they provide as well. Yeah.
Excellent. I mean, you're a fantastic architect, Serge. We need you in the health system. You're fantastic. Thank you very much, Serge. Raymond, just a few words as well. I want to go back to this notion of culture and infrastructure. And if you can give us some examples on how how it can be actually translated, this interaction.
Well, there's the clinical aspect of it, the way, as I said,
Yes.
the population or related to health, which is different from us. There's a gap in between. When we see a doctor in Europe, the doctor is about the same level as we are, because we're educated and we can understand what he says or she says. But then there's a gap in between mostly the population in the rural areas between you see these doctors as like someone very far away from where they are. So I think there is a relationship that needs to be built, which was there before, because before they had the healers. The healers were part of the tribe, and then they were very close to the population. But now when we implemented the European or the Western model, there was a distance that took place in between patients or populations and doctors or nurses. This is one thing. The other thing is we have to stop building like we build hospitals in Europe. There is a concept which is called biophilic architecture, which is very related to nature, actually. It's mostly, they used to be living in huts which were round, and this has a symbolic aspect for them. And then suddenly we brought them into rectangular buildings, which are not what they want. But there's some sort of a conflict, because many of the doctors in Africa or have been trained in France or in Europe, and when they come back, they want to implement the same system as they have. So at some point, we have to make a balance in between what the patients want and what the doctors want, and so on. So I did a project in Burkina Faso. I could send you the picture. It was with the Invest International from the Netherlands. And it was designed, it's not built yet, but I designed it onto what we call the village hospital. So it's inspired by the traditional villages in Africa, how you build up the hospital. So it's more like small houses and everything. So it's more organic, and it's not orthogonal. And I think this is a direction that we should take. And it's more resilient, obviously, because it's not like a one sound building. If there's an earthquake and you have only one building, it's going to break into several parts. If you divide the buildings, like you have like a composite type of architecture with different wings, one wing can be affected and the other one may not be affected. So that increases also resilience. So these are the kind of things that you can look also a project I did in Denmark, the new North Zealand hospital. It's designed as a clover leaf, and this is biophilic also. So it really integrates into nature.
Excellent. Thank you very much. Thank you, Raymond. Thank you. Very inspiring. We got in the Q&A, we've got a question from Pedro. I'm not sure whether or not it is a question but maybe that's for Raymond or Serge. It's about examples of how reducing the number of particles in the air in hospitals can save energy. I don't know whether or not it's a question, not being an architect. Serge or Raymond, if you want to address this question.
Actually, I have to go. I have another meeting going on.
Okay, no problem. Thank
I'm
you,
sorry.
Raymond. Thank you very much.
Désolé.
Absolutely.
Yes.
Sorry.
Sorry.
With great pleasure. Thank you very much for being with us. Okay, bye-bye. Serge, you want to take this one? Then there's no choice.
I don't think I quite understood the question by what he meant by the number of particles in the air to reduce energy. But what I could say in terms of our intervention is to make sure that the systems that are put in place, like what we had in the R2H, the chiller system that made sure the chiller system that also combined chilling and heat recovery, so that part of the energy that is used into the HVAC system could also be recoverable and also saved to compensate on other hospital needs. And of course, part of this is to ensure that the system improves the air quality within the indoor spaces to provide, of course, the infection control benefit of that, but also the heat recovery system helps to recover the energy spent on such a heavy system to compensate on other hospital systems. So that would be my reflection on that in terms of air, but I don't. But in terms of outside air, I don't sure I quite picked the question. Yeah.
Thank you, Vera. You want to answer or no? No. Okay, good. I can see you appearing. Okay, excellent. I think we don't have any other question online, so I'm going to conclude this webinar. I just want to thank all the panelists, the speakers, Vera and Serge who are online, Sonia for helping organizing this webinar, who has been fantastic, and as well all the speakers who have contributed. Thank you very much to all the attendees. This is not the end. It is the start of a consultation process. You're going to have another webinar organized early 2026. The date will be communicated a bit later. As mentioned by Agnès, we are currently working on a position paper, and the colleagues at AFD, Agence Française de Développement, are also providing a lot of feedback. And I suspect this document will be shared with you for feedback and input. And I think it's great that this community is fantastic, and there's a lot of great feedback, and I think and great as well initiative that has been implemented, and you have tested and evaluated this implementation. So I think it's fantastic. So on these final words, I thank you very much, and I will see you at the next webinar. Thank you very much.
Thank you.
Thank you.
Thank you,
Bye-bye.
everyone. Thanks to all speakers, and thank
Bye-bye.
you, Carl, for this fantastic moderation. Really great.
Take care.
Thank you.
Bye-bye.